Hello, everybody. My name is Will Vaughn. I'm the Health and Safety Chairman for Monmouth Council. Back with you for another update in first aid. This one designed specifically for Campmasters, but with the understanding that the folks who serve as Campmasters very often fulfill other roles in scouting programs, particularly as commissioners during summer camp and things like that. Apologize for any mishaps during the recording of this. I'm coming off a night shift, but I'll try to give you the best I have to offer here. Um, so things have changed a little bit since the previous installment I did on YouTube for the scouting crowd. Um, the COVID precautions have basically all been rescinded at this point. So some of the things that we've spoken about in the recent past as precautions for giving first aid really don't apply to the same extent. We're not worried about masks. We're not worried about trying to assess our patient from 6 feet away. Really, the key precaution across our program at this point is summarized in the phrase "stay home when sick," and that's kind of where it is. We don't have a formal screening process for that anymore either, but that's the message that we try to reinforce. So, the good news is we're back to more or less a normal program. You know, we're not trying to chase people out of buildings or lock doors or anything like that right now. We're, back to great customer service and trying to offer our scouts and scouters the best we have. Back to first aid. I want to give you a review of the most useful first aid for a campmaster or volunteer commissioner or what have you to know. We have no expectation that an individual in these roles is going to be an expert in first aid, as would be an EMT or someone with a higher level of training. But we do understand that, number one, everyone in scouting has a certain amount of first aid background. And number two, if you're staffing the camp for the weekend, you may be put in the position where you have to address an emergency or even a minor first aid situation, at least initially. So let's talk a little bit about that. In some cases, you'll be blessed with some help very close at hand. As a campmaster, you may have someone working with you who has a higher level of training, or perhaps there's an event going on and there's an event first aider who will take responsibility for this entirely. If you're up at Forestburg as a commissioner, or you're assisting as a volunteer at Quail Hill during the summer, we staff a health officer, usually an EMT or a nurse, who becomes the point person for that and can be the person to whom you refer folks with first aid situations. When we talk about first aid in camp, we do it with the understanding that the vast majority of situations are minor in nature. And I think that's probably been your experience as unit leaders or serving as campmasters. Like, if somebody's walking in the door, it's probably something that you know how to manage from being an adult or from being a parent. But we have had medical emergencies in our camps over the years. I've been involved with this for close to 30 years now. And basically everything that I speak to when I'm training this camp staff, along with other members of my committee, or the things that I'm going to talk to you about in the remainder of this video, every one of these things has happened in one of our camps, and in some cases multiple times. We've had 3 cardiac arrests in our camps in the past 30 years, which gives us one about every 10 years. So when we speak about things like CPR and defibrillators and things like that, it's not really a theoretical thing. It's a very practical thing, and the thing that we focus on inside my committee is we can't predict who will be there when such a thing happens. So we want to make sure that we equip everyone who's minding the store with the tools to be successful in these cases. Um, first thing I want to talk about is our equipment. Uh, so in Last Lodge, there is a first aid room. Inside the first aid room is a jump bag with a significant amount of first aid equipment and supply. You'll note that there are things in there that may be sort of above your pay grade in terms of what you know how to use, and that's fine. Leave them alone. Use what you know. Anytime we respond out to a situation in the camp, we want to make sure that we take that bag or the equivalent. We want to make sure we take some type of communication device, a cell phone, a radio if it's appropriate, like in summer camp situations or events, or both. And the third item would be an AED defibrillator. Our defibrillators are now in the Ranger's truck, on the front porch of Lawrence Lodge in a cabinet, on the front porch of Last Lodge in a cabinet, and in season in the office of the pool. The reason we take an AED to everything is that there's no going back. If the report of the emergency is inaccurate, speaking as having been in EMS since 1996, I can tell you that that's often the case. Eyewitness accounts are notoriously unreliable. You don't want to go to a scene with the understanding that someone has fallen and find out that they fell because they had a heart attack and now they're in cardiac arrest. So we always roll with an AED. It's better to take it and not need it rather than the opposite. In season, if we're going to investigate a report of something in the field, we're going to let the health lodge know so that they can back us up. In weekend operations, if we're leaving Last Lodge to deal with an emergency, or if there's an emergency in Last Lodge, pretty early on, we're going to make sure that we notify the ranger. Same thing at Forestburg, because our rangers play an important role in coordinating resources in an emergency. They may or may not become the principal individual treating the patient, but we utilize our rangers in a role kind of as incident commanders where they deal with the bigger picture questions, including, transportation of the patient and coordination of outside emergency resources, things like that. So when we approach an emergency, the first thing we do is we survey the scene, look for hazards, try to determine what's going on, and very quickly determine, is this something relatively minor, or is this something where we need to escalate the situation and call for help, either from resources in camp or resources outside the camp. One of the things that I like to discuss in particular for folks like Campmasters is how to make an emergency phone call. This is something that benefits from an understanding of the process, especially because you're likely to be the ones doing it. The first thing I'll say is obviously you can call 911 from a cell phone, but it's somewhat useful to call from a landline if it's an option for you, because the way that a 911 center is designed, if you call from a landline, it will show the address you're calling from as soon as the dispatcher picks up. So, but if not, call from a cell phone and understand that the first question they're going to ask you is, what is the address of the emergency? If you look at our telephones in camp, there's an emergency phone numbers list posted next to them. That's true for both camps. And at the top of that list is the address of the camp and the telephone number of the camp. So the reason they ask for the address first is, should you be disconnected, or should a caller hang up in a panic, or what have you, at least they can send a police officer to that scene and have some degree of help arriving and someone who's going to ascertain what's going on. The second thing that they will ask for is the phone number you're calling from that you can take a call back on. And that would be if they need to call back because the line was disconnected, call dropped, if they need to call back for clarifying information, and in particular, if the ambulance is arriving and can't find you, they're going to want to call back and get better instructions on where to go, or ask for someone to meet the ambulance. The third thing that they'll ask for when you make an emergency phone call is, tell me exactly what happened, is what they'll say. And you're smart people. You'll obviously try to be somewhat succinct in describing what's going on, and they'll want to know, uh, you know, yes, your version of what happened, but they'll also ask some clarifying questions like, is the person awake? Is the person breathing? Is the person bleeding? They're trying to determine what's going on, how bad is it, and what type of resources they need to send. In addition to where you are. Um, from the 911 center, they're going to want to determine, do you need just an ambulance? Do you need paramedics? Are there even more complicated things going on? And so they'll try to get that from you. One of the things about the algorithm that a 911 dispatcher uses to interrogate you is it kind of assumes that you're with the person who needs help. And if you're not, you may have to clarify with them that you're not. So let's say, for example, you're in Last Lodge, your partner in crime went out to investigate a situation, in the field, and you're passing along information. You may not be able to answer all the questions of the dispatcher, just make it clear where you stand. And that's kind of ditto for, it, like, in some cases, we're going to call 911 right away rather than going to size up the situation. For example, somebody runs into Last Lodge and says, the Scoutmaster collapsed and we're doing CPR on them. Well, we don't need any more information than that. If that's the case, then we're going to, get the ball rolling on 911 right away. We may not have any more clarifying information to share with the dispatch center. So once that's the case, aside from rendering first aid to the individual, we'll also want to work with the ranger to make sure that someone meets the ambulance and directs it to the scene. This is where the rangers get heavily involved in, we operate a little off the beaten path. So, do we get the ambulance to the scene, or do we get the patient to an area that's accessible by ambulance? That's where we lean on them, and in season on our health officers. Um, the first priority in first aid is now bleeding. I know over the years everybody's taken CPR courses, and we've really heavily talked about airway, breathing, circulation, and those are still top priorities. But the control of severe bleeding has become the number one priority in first aid. And we've learned this from war, just like everything else we know about injuries. So when someone is bleeding, of course, the first thing we do is take precautions for ourselves. So we make sure we put gloves on, and then eye protection. If that's appropriate, if blood is spurting, all that stuff is in our first aid kits. The way we control bleeding 99% of the time is with direct pressure alone. In all our first aid kits, we have gauze and larger compress bandages, roller gauze, and triangular bandages, and all sorts of things to try to put direct pressure on things and make pressure bandages. And as long as we don't release the pressure, as I said, that tends to be the solution almost 100% of the time. Really, the key is that you want to provide direct pressure with your fingers and a dressing to the exact source of the bleeding. And I know that it's been emphasized in first aid classes over the years that you're never to remove a dressing because clot is forming and so forth. And that remains true, but let's make sure that we're providing pressure to the exact point where the bleeding is. So if we have to remove the dressing for an instant to visualize where the pressure needs to be, we can certainly do that. But that being said, the number one reason why bleeding doesn't stop is we keep investigating whether it has stopped by taking the pressure off, and that's not particularly helpful. Same thing applies for nosebleeds. If you can put direct pressure on a wound or on a nosebleed for 10 minutes, you're pretty much done, as long as you can not succumb to the temptation to see if you were successful too early. If there is a hole associated with the bleeding, let's say, an axe went into somebody's leg and, there is a gap where the bleeding's coming from, or a hole, you want to take gauze and fill up that gap so that you can get direct pressure to all the different vessels that are bleeding. We'll go from there. If there is a catastrophic injury, and the example that I would use is like a chainsaw accident or something like that, something where the blood's coming fast and furious, and there's just no stopping it, then we don't want to hesitate to utilize a tourniquet. In the past, tourniquets were discouraged, but again, based upon wartime experience, we found out that tourniquets can safely be on for hours without resulting in amputations or anything like that. It really doesn't cause any harm. Um, on the flip side, what can cause harm is losing your entire blood volume due to inadequate bleeding control. So, in insofar as we wish our patients to survive, uh, we don't hesitate to use a tourniquet now. Ideally, we utilize a commercial purpose-made tourniquet. However, if the materials we have available are those for an improvised tourniquet, you can use a triangular bandage or a neckerchief or what have you, and make an improvised tourniquet. And then, if needed, replace it with a commercial tourniquet when one arrives. When I talk about a commercial tourniquet, the ones we stock in camp in our jump bags in the health lodge and the Rangers first aid kits and things like that, is the combat application tourniquet. It looks like this, and by design, it's meant to look like a commercial version of an improvised tourniquet. These tourniquets are also in first aid kits that are co-located with the AEDs on the porch of Last Lodge and Lawrence Lodge. And really, they're quite simple to use. God forbid you need to use one. There's a Velcro strap, so you would put that onto the arm or onto the leg. The way we remember where to put it is high and tight, like a military haircut, like a crew cut, high and tight. You want to make sure that the Velcro strap is as tight as possible so you can get the maximum amount of a tourniquet effect by turning the windlass. So you turn the windlass, there's a little plastic piece that holds the windlass once you've got it nice and tight, and then there's a strap that goes over it to hold it in place, and you can write on that strap with a Sharpie what time the tourniquet was applied. There are markers with all these tourniquets for that reason. The number one pitfall with these tourniquets is not making them tight enough. So if there's a question, make it tighter. Obviously, if you put a tourniquet on someone, you need to call an ambulance. I guess that kind of goes without saying. The topic that we discuss kind of in tandem with bleeding is shock. So shock can be caused by a number of different things, but in the first aid scenario, it tends to be caused by blood loss. And when you lose enough blood, you're not getting enough oxygenated blood to your organs, and you go into a life-threatening condition called shock. So how do we treat shock? Well, number one, stop the bleeding or address whatever the other issue is. For example, anaphylactic shock, we would treat that initially. We want to put the person flat, and we want to keep them warm. In the past, we've talked about raising the person's legs, and we have found out through scientific studies that that doesn't actually work. So the way we position someone is flat. Okay. So bleeding's the number one priority. Second priority is breathing. So if someone is unconscious, our first question is, are they breathing or not? If they are not breathing, in all likelihood, they are in cardiac arrest. You don't last very long not breathing with a pulse. Tends to be come as a package. So if someone is not breathing and doesn't have a pulse, then we want to go ahead and start CPR, and we want to apply a defibrillator. Again, the defibrillator should have come with you if you're responding into the field. If you don't have one, you send for one. Obviously, if someone's in cardiac arrest and an ambulance hasn't been called, then that's of the highest priority as well, to get the cavalry coming, including paramedics who bring the rest of the toolbox, include for medication and intubation and things like that. We encourage CPR certification among everyone who works in our camps in any capacity. In the event that you don't hold a current card, it's not a license. You don't have to have one to perform CPR, so please don't hesitate. Push, one hand right on top of the other, shoulders over your hands, elbows locked, right, straight up and down on the breastbone, between the nipples, full recoil, because you're pumping. Right, you're squeezing the heart between the breastbone and the spine to try to push blood out, and then you're recoiling to let negative pressure pull blood back into the heart. If you know how to give the breaths, there are pocket masks in all the various first aid kits everywhere in the vehicles and the program areas, and obviously the ones we use for emergency response. Um, if there's not one available or you don't know how to use it, you can do compression only CPR while awaiting help. One of the interesting things about doing chest compressions is the negative pressure that draws blood back into the heart also draws air into the lungs. So it is a somewhat effective strategy for the short term in both breathing for the patient and uh, replicating the work of the heart. If you have the AED available, that's very straightforward to use. Also, instructions are right on the front. Our particular AEDs, there's a handle that says pull. You pull it, and that reveals the pads and also turns it on. There's a diagram for where to put the pads on the chest, and then the AED will give you instructions on how else to proceed if you're not already familiar with it. If someone is unconscious but they are breathing, then we like to put them in the recovery position. The recovery position involves putting one arm up and then rolling the person onto their side. And this does a number of things. One is it keeps the spine in line because the arm holds the head in a neutral position, and then it allows the tongue to fall forward so it's not obstructing the airway. And if the person were to vomit or drool or what have you, those secretions aren't causing them to choke, but rather just draining out of their mouth. So we like the recovery position a lot. Next thing related to breathing is choking, and there's no change in that procedure. The abdominal thrusts, or what's been known as the Heimlich maneuver, is still appropriate. So you would stand behind the person, one foot between their feet, 1 foot back, so that you're in a position to catch them if they were to go unconscious. Thumb into their belly, above their belly button, but below their rib cage. The other hand on top of the fist, and then inward upward thrusts until the item comes out or they become unconscious. If they were to become unconscious, we would just do chest compressions and periodically look for the item in the mouth. Next thing related to breathing is anaphylactic shock. So this has become more of an issue over the years. And in fact, in recent years, we've dealt with it just about every summer at Forestburg in one capacity or another. There are enough people who are allergic to either bees or certain foods, mainly nuts, nut butters, seafood, things like that, that there are a lot of people out there with a history of severe allergic reactions, a lot of people carrying EpiPens, and despite the best precautions we take, sometimes these people do get stung by bees. Sometimes these people do come into contact with foods that they're not supposed to eat. Fortunately, these folks generally know the situation. They avoid these things and they carry medication, EpiPens, for that eventuality if they're needed. At Forestburg, we have a New York State law that allows us to stock EpiPens, so we have them available in our major first aid kits up there. You know, in the Health Lodge, in the Ranger's truck, in season at Todd Lodge, and so forth. And we also have them at Forestburg that can go out on outpost overnights and high adventure and that sort of thing. But that's neither here nor there. The when you have someone who is in anaphylaxis, most of the time there'll be a history of this, and there will be a known exposure to the offending agent. However, it is possible that it's the first time. Either way, as soon as we recognize someone is having a severe allergic reaction, we call 911. Again, we want to get the cavalry coming because our treatment for this, the EpiPen, is really a stopgap measure. It's not a total solution. It's not an antidote. And these individuals need the additional capabilities that paramedics in particular bring. So not just the first dose of epinephrine, but all the other medications and treatments associated with it. So when we talk about a severe allergic reaction, we're not talking about a rash, and we're not talking about hay fever, these sort of more mild allergic reactions that you might see to pollen or that sort of thing. What we're talking about is a reaction of the body that's so violent in trying to keep the agent out that it ends up killing the individual in the process. And so, how does it do that? Well, it closes your airway so you can't breathe. Your tongue swells, your lip swells, your throat swells, and it's trying to keep you from eating it or breathing it. The patient will wheeze. Most of the time, you'll see a rash all over the body. That's kind of a telltale sign, along with the breathing problems and the airway problems. And about a third of the time, the person is actually in shock. We utilize this term anaphylactic shock, but for the person to be pale and have a low blood pressure, thready pulse, like sweaty, like the things that we normally associate with shock from blood loss, for example, that's about a third of the time. Regardless, we want to call 911. If there's an EpiPen available, we want to use it. So I have a trainer here to show you. If you have the opportunity to play with one of these, I highly recommend it, just so you're not interacting with it the first time in an emergency. If for whatever reason this is not comfortable for you, then you can hold off. If possible, for someone else to assist who's more familiar. It goes without saying that the patient should be familiar, but sometimes they're not really in good shape to administer this to themselves. So you want to be prepared to do it. So the most important thing to understand about an EpiPen is that there's two ends. And they have tried color coding them and doing all sorts of things over the years. And invariably, the same problem occurs no matter what type of engineering is built into this, and that is that people accidentally inject it into their fingers. So the way that we work around this is we absolutely 100% honor the rule that we never put our fingers on either end, no matter how sure we are of which is the orange business end and which is the blue safety cap. So we hold it like this. When we're giving it to someone, we pull the blue safety cap out, and now the thing is live, and the orange business end goes into the outside of the person's thigh, like this, and we hold it for 10 seconds. The needle sheaths itself for the EpiPen model. There are some other ones that don't do that, but the other dominant one on the market, the AviQ, will talk to you. It has a voice instructions, so that may make up for the fact that you have to deal with avoiding getting stuck after it comes out. You can rub the area to enhance the absorption. It is designed to go through clothing, but just be mindful of how thick the clothing is and whether there's a cell phone in the pocket or a pocket knife or what have you. In some cases, it really does make sense to either cut the pant leg or just pull the person's pants off of the thigh so that you can actually go to skin and make sure that the dose is given. It's a natural reaction to, for the person to pull away. So we want to make sure that we hold the injection in place for 10 seconds so that all of it goes in and none of it gets sprayed into the air. Again, very important that 911 is called with this. I guess the other thing that's worth mentioning is just like, someone having an asthma attack or what have you, like if the emergency's happening and this is somewhere else, then we probably want to send somebody to get it. Okay, next topic, head and spine injuries. Most bumps on the head are trivial. However, it's worth mentioning that, when people get their bell rung when they have a concussion, it's not like it used to be. We don't send them back into the game. We don't put them right back in the scouting activity. Football players who get their bells rung these days sit on the sidelines and get evaluated, and we kind of do the same thing. If somebody has persistent symptoms, dizziness, nausea, any type of confusion, what have you, then we don't put them into strenuous activity and we have them evaluated. If someone has a significant head injury, they were knocked out cold, or they remain confused or what have you afterwards, then that's an ambulance type of job, and we generally don't move those people um, in the event that they have more serious injuries. Um, it's kind of ditto for concerns about neck and back injuries. Again, you can have trivial things there too, but if someone has a significant mechanism of injury, example I give is like somebody falls off the roof, or people are horsing around, somebody gets dropped on their head, and then there is severe pain in the neck or back. There's numbness and tingling in the arms and legs, paralysis, what have you. We leave them where they are, and they don't get moved without expert help. And certainly if we have to move someone in an emergency before help arrives, then we're going to do so with the direction of our rangers or health officers on site. If someone is with a spinal injury in the pool, when the pool's under operation, then whoever are the lifeguards at the pool will take charge of removing them from the water safely according to the procedures that they're trained in. All right. Muscle and bone injuries, you've got your kind of trivial bumps and bruises, and there's ice packs for that, and most of the time nothing more is needed. A sprained ankle, can get wrapped and elevated and iced and what have you with follow up by the parents. If there's any concern that something might be broken or not, we err on the side of treating it as a fracture, splinting it, sending it to the hospital. In general, if someone has a fracture and they're in the field, we don't move them without a splint. And how that works out kind of depends on how significant the injury is. I mean, certainly if it's a wrist or something like this, or we can utilize a SAM splint, as you've probably seen before. They're in all our larger first aid kits, including the jump bags. If it's a broken leg or something more serious like that, we'll probably leave them where they are, pending the arrival of additional help. I'm not expecting a Campmaster to deal with that solo. Understand that when someone does have a fracture, we want to consider the fact that it took a significant amount of force to break that bone. We just want to make sure that we're not missing another serious injury while we're kind of distracted by the ugly bone injury. So just keep that in the back of your mind. Going back to the more nickel and dime stuff, small cuts can get cleaned with soap and water or antiseptic swabs, whatever you have available. If it's not going to need stitches, you can put triple antibiotic ointment on it and a Band-Aid, and you're done. More serious stuff will just, stuff that needs a tetanus shot or needs stitches or what have you, that can just go to the hospital, and we'll just bandage it to control bleeding before it goes. One of the mantras there is kind of, if in doubt, send it. There's really not a whole lot of harm if you're not sure, whether it's something to be. Burns, again, lots of small burns in camp. Most of them, you can run them under cool water as soon as possible. If you put it under running water for 10 minutes, that really limits the extent of the damage, because the water will pick up the heat and carry it away. If you have blisters developing, if it's significant, then probably go to the emergency room. The more serious burns, like someone got caught on fire or what have you, then that's an ambulance call. That's a call to 911. We'll still cool it though, and then treat for shock. Something in the eye, in general, gets flushed out with water. If it's a chemical, it gets flushed out immediately, and we keep flushing for 20 minutes. If it's something, smaller, then, we can just flush it until we're pretty sure we get it out. I spoke briefly about nosebleeds before. We want to have the person pinch the bridge of their nose and lean forward, and the direct pressure rule applies as long as we don't stop periodically to investigate whether we were successful or not. We're usually going to stop all nosebleeds with 10 minutes of consistent direct pressure. All these things I'll mention at this point. If you're rendering first aid, it needs to go in the first aid log, which sits in the first aid room of Last Lodge. And you'll capture the first name and last name, the age, the troop, what happened, and what you did about it. If it's something more serious, the Rangers will help you with the required incident reporting from there. I want to speak briefly about some of the kind of life-threatening sudden illness that you might see. First thing is a heart attack. So a heart attack is when blood flow is obstructed to the heart. Right? The heart has its own blood supply, and if one of those arteries gets obstructed by a clot, that portion of the heart will start to die. That's a heart attack. Generally happens to adults, although there's nothing that says it couldn't happen to a kid. It's just very unlikely. So it tends to be adults, and the presenting problem tends to be chest pain associated with jaw pain, left shoulder and arm pain, sweating, shortness of breath, nausea, what have you. For elderly people, for diabetics, for women, and especially elderly women or elderly diabetics. Sometimes there isn't chest pain, but they'll have all the rest of the things. So if somebody looks pretty sick, then you can treat it as a heart attack regardless. We want to make sure a defibrillator is available. We're prepared to do CPR. We want to call 911 right away. We do offer these people now aspirin, and we have aspirin available in the jump bag in Last Lodge. We have aspirin available through the Rangers. We can give the person 4 baby aspirin to chew and swallow as long as they're not allergic. This may seem like practicing medicine, but I'll tell you that if you call 911 and say that someone has chest pain, they'll advise you to do that over the phone anyway. Stroke is kind of similar, except it involves the brain, not the heart. So blood flow has been deprived for part of the brain, either because of clot or because there's bleeding. Generally, that looks like slurred speech, a droop on half of the face, and paralysis or weakness on half of the body. If that's the case, then we call 911 right away, and we take note of what time it started. If the person is unconscious or can't manage their secretions, drooling, what have you, we can put them in the recovery position. As we discussed before, that works very well. Next topic is asthma, a very common thing for our scouts, and more common than it was in the past. So asthma is a reactive airway disease, meaning the bronchi constrict because of exposure to something. Could be some type of allergen, could be exercise, cold air, what have you. Makes it difficult to breathe. In particular, it makes it difficult to exhale. People describe it as breathing through a straw. These people generally will have an inhaler. The drug that is in those inhalers is almost invariably albuterol. If they take the inhaler and then get better, great, that's what was supposed to happen. We don't worry about it. If the albuterol doesn't work, it's not available, the person's getting worse, they're getting drowsy, the lips are blue, what have you, don't think about it anymore. Call 911 and we'll go from there. Next thing is diabetes. Right? Diabetes is an issue managing sugar. We have kids with diabetes who generally don't make insulin in their pancreas, so they have to inject insulin in order to metabolize sugar. And then we have older folks who have type 2 diabetes, which is related to insulin resistance. Either way, it's possible for the blood sugar to be too high or too low. In general, if someone becomes sick acutely, meaning they get confused, they get sweaty, what have you, we presume it to be low blood sugar. So as long as they're awake and they're able to swallow, we give them some type of sugar by mouth. You can give them orange juice or non-diet soda or jelly beans or lifesavers or anything like that. We stock glucose gel in a packet in our jump bags and larger first aid kits for this purpose. It's very important not to give it to someone if they're unconscious or unable to swallow. If that doesn't make them better, or if they are unconscious or unable to swallow, then we have to call 911 so that we bring the capability of injecting sugar. The last illness to talk about is seizures. It's not an anomaly anymore for someone to have a seizure in camp. We serve developmentally disabled folks in scouting, and thank God we do. But sometimes they have seizures, and in that case, it's not unexpected, and we treat it appropriately. So When someone has a seizure, it's abnormal electrical activity in the brain. Generally, they'll fall to the floor and they'll become very stiff for an instant, and then they'll shake, and then it'll be over. If someone has a history of seizures and they have a seizure, it's not necessarily an emergency, although we'll want to make sure that we protect the person from injury. We'll want to, move the furniture away, something under the head so they don't hit it on the floor. We'll want to roll them on their side so that, again, the tongue doesn't obstruct their breathing and that sort of thing. We do not ever put anything in the person's mouth. And we've probably gotten to the point where we don't have to say that anymore, but it was so ingrained for so many years that I feel like I have to emphasize it every time I teach. We don't stick things in people's mouths for a couple of reasons. Number one, you can get your fingers bitten as the first aider. Number two, most tongue biting happens at the instant the seizure starts, not subsequently, so you're not accomplishing anything. You can break the person's teeth. And you can also cause an airway obstruction by the item that you stick in the person's mouth. So we do not do that at all. When a seizure is complete, the person generally is confused because their brain was deprived of oxygen briefly. And so that's expected, but we also expected it within a couple minutes that they're going to kind of return to their normal. If they don't, or if they keep having seizures, then that's an emergency. We have to call 911. Ditto for someone who is having a seizure for the first time. If someone has never had a seizure before and they have a seizure, then that's got to go by ambulance. We don't know why it happened. Going back to our kind of developmentally disabled scout who has a seizure, we can lean on the leadership and we can talk to the parents and find out, is this within kind of the normal pattern of seizures, or is this an anomaly? Last first aid topic is heat and cold emergencies. In the winter Campmaster season and the shoulder seasons of fall and spring, it's easy to get cold, particularly if it's wet. So, if someone's shivering and they suffer from the umbles, as we call it, stumbles, grumbles, mumbles, fumbles, we want to warm them up. Easiest thing we can do is bring them inside. If they're in wet clothes, get them in dry clothes. If they're improving rapidly, we can give them some hot chocolate or something like that, and get them back to the norm. If they're significantly hypothermic, meaning their mental status has changed, they're confused, then we really have to rewarm them aggressively, and we have to call 911. When the brain's unhappy, people get confused, and that's our sign that there's a life-threatening problem, whether it's sugar or oxygen or bleeding or hot or cold. On the heat side, generally heat illness starts with dehydration. When someone's dehydrated, then they can easily be overcome by the heat. Heat exhaustion is the first stop on this, and it generally looks like shock. The person's sweaty, the person's pale, the person doesn't feel well, they're nauseated or dizzy, and so we want to bring them into the air conditioning if possible, or at least the shade. We want to take off excess clothing. We want to have them rest, and we want to have them sip a little water and see how they do. If they don't improve, then we can kind of escalate the care. And if they have heat stroke, meaning that they're confused, they have a change in mental status, or they're unconscious, then we have to treat that as a real medical emergency. Cool them rapidly, undress them, soak them with water, fan them, try to get evaporative cooling, and call an ambulance immediately, because that has life-threatening implications, particularly for the brain. So hopefully that gives you a good review and update for the types of first aid situations you might see in camp. The good news is that there's always help available in one form or another. There may be help close at hand in the form of a health officer. There may be help that's a phone or radio call away in the form of our rangers. And there's always help in the form of the emergency room or 911 if you need it in a pinch. So you're never alone. But But I think, as you'll agree from experience, the vast majority of what you deal with are things that are within the realm of scout first aid that might as well come right out of the handbook. So that being said, thank you for all that you do. It goes without saying. I hope that we've provided the tools for you in terms of training and equipment to be successful. As always, if there's anything that the Health and Safety Committee from Island Council can do for you, please don't hesitate to reach out for us. Thanks for your attention. See you soon.